I invited my mom. I wonder if she's going to join.
It's good moment to see more people can join and see the numbers increasing, so that's good. In the meantime, welcome everybody. Welcome to the first webinar of the National Hispanic Hepatitis Awareness Day. And today we observe the impact of hepatitis on the Latino community, and this has been going since 2013, organized by Latino Commission AIDS and Hispanic Federation. Today we're going to have our first webinar, as I mentioned, with the collaboration of NASTAD. To commemorate the NHAD, we're doing this webinar, which the presenter will discuss the burden of the viral hepatitis in the Latino community and in general, updated guidance and opportunities to increase screening and vaccination in the Latino community. The webinar will also highlight partnerships between health departments and community organizations to increase awareness, testing, and linkage to care. At the end, NASTAD will also discuss available resources for Latinos in English and in Spanish about hepatitis. Today, we have two representatives with us, two very important persons that are collaborating with us today. We have Rita Isabel Lechuga. Dr. Rita Isabel Lechuga Isabel is an associate director on the hepatitis team. As the associate director, her scope of work includes expanded oversight of team work plans, implementation of relevant strategic plan objectives, and fiscal management and oversight. Previously, she was part of NASTAD's global team overseeing HIV case-based surveillance system, strengthening interventions in 5 countries in Central America. Before NASTAD, Isabel worked as a consultant for the Regional Office of the World Health Organization, WHO, leading research studies on HIV, viral hepatitis, and child health as a physician with the Mexican Secretariat of Health. Yeah, Mexico. Isabel holds a Doctor of Medicine from the National Autonomous University of Mexico and a Master of Public Health from George Washington University. Beautiful university, Mama. And we also have Sequia Grabs, also for NASTAD. Sequia Grabs is a manager on the hepatitis team as well. She primarily supports prevention and surveillance capacity building through NASTAD's online technical assistance Center for Hepatitis. Prior to NASTAD, Sequia was the viral hepatitis program coordinator at the South Carolina Department of Health and Environmental Control, where she worked with community partners on hepatitis C virus testing and referral and developed a comprehensive statewide viral hepatitis strategic plan. She received her MPH of Global Health from George Washington University and the BS in Health Educator at Howard University. So thank you, Rita. Thank you, Sequia, for being here with us and presenting the webinar for NHAD and collaborating with the Commission. So it was yours. You can share your screen and go ahead. Thank you.
Perfect. All right. Thank you. That lovely introduction. I never know what to do with myself when someone's reading my bio. I'm like cringing a little bit. All right. So again, I am Isabel Lechuga. I am an associate director on the hepatitis team, and I use she, ella pronouns. And I am joined today by my colleague, Sequia Grubbs, who is a manager on the hepatitis team, also at NASTAD. So I want to recognize, first start off recognizing the Latino Commission on AIDS for their joint effort with the Hispanic Federation to establish National Hispanic Hepatitis Awareness Day in 2012 or 13 in response to the impact of viral hepatitis on Hispanic/Latinx communities, commemorated every May 15th. All right, so today, Sequia and myself will be giving an overview of who NASTAD is, what viral hepatitis is, a bit about its burden, existing federal commitments and updated guidelines, and state and local partnerships, resources, and hopefully ending with enough time for discussion with the audience. So in an effort to be consistent, we will be using the terms Latinx, Latine, Hispanic, Latino, Latina interchangeably to encompass the umbrella of people that identify as such. That being said, think about like my parents that hail from the state of Chihuahua. They would say Latinx. ¿Qué es eso? So no, but I want to make sure I make this point. So I will recognize the words of Alan Velázquez Lopez in The X in Latinx is a wound, not a trend. That quote, "It is important for us to not normalize Latinx, but to engage in critical reflection of how violence against lesbian, gay, bisexual, transgender, intersex, asexual, plus Latin Americans have been accepted by Latin American people to the point that LGBTQIA+ Latinx have had to create a linguistic intervention in the hopes they can live a livable life. So for this next hour, I will ask that we put on our critical thinking caps and that we pivot from either or thinking, which is seeing incidents of inequity as isolated events, to systems thinking via understanding context and intersectionality, seeing patterns and holding contradictory thoughts and feelings simultaneously, paternalism to partnership, which includes a commitment to consulting all parties and clear decision-making, pivoting from competition to collaboration, meaning to commit to taking the time to build relationships based on trust and focusing on building a bigger pie rather than fighting over a slice, shifting to power, sharing which values ideas at all levels and makes space for them to be heard, and finally working in community, specifically from a movement lens and understanding that to change everything, it takes everyone, and also understanding the interdependence of all social struggles. So who is NASTAD? We are a nonpartisan, nonprofit membership organization representing public health officials that administer HIV and hepatitis programs in the US. We represent all 50 US states, District of Columbia, Puerto Rico, US Virgin Islands, and 7 local jurisdictions from the CDC and the US Pacific Island jurisdictions. Our main areas include strengthening governmental public health through advocacy, capacity building, and social justice. We recently revised our mission and our vision. So our mission is to advance the health and dignity of people living with and impacted by HIV/AIDS, viral hepatitis, and intersecting epidemics, with the vision of a world committed to ending HIV/AIDS, viral hepatitis, and intersecting epidemics. NASTAD's hepatitis portfolio mainly consists of 2 cooperative agreements of federal grants with the CDC. In August of 2018, NASTAD became one of 39 recipients of the CDC Center for State, Tribal, Local, and Territorial Support 5-year funding opportunity, which is strengthening health systems and services through national partnerships. And through this cooperative agreement, we work directly with health departments implementing prevention and surveillance activities. And this work consists of HepTAC, which is our online technical assistance platform, and the VLC, which is a virtual learning collaborative. It is designed as a training series to help health departments build core competencies in viral hepatitis prevention and surveillance activities. Additionally, NASTAD oversees HepNet, which is the Hepatitis Network for Education and Testing, which is work done in collaboration with our partners, National Viral Hepatitis Roundtable and the National Association of County and City Health Officials, which focuses on improving the health of people who inject drugs. So together, HepNet is a growing network of health departments, syringe service programs, community-based organizations, healthcare providers, and other partners that serve PWID. So there is a QR code on the slide. I don't know if it works for folks. I hope it does. But y'all can also get in touch with us if you're interested in learning more, signing up for HepNet. All right, so what is viral hepatitis? Generally, hepatitis means inflammation of the liver. And the liver is a vital organ that processes nutrients, filters blood, and fights infection. So when the liver is inflamed or damaged, its function can be affected. And in this instance, we're referring to hepatitis being caused by a virus. And in the United States, the most common types of viral hepatitis are hepatitis A, B, and C. Many people with hepatitis do not have symptoms, and they do not know that they're living with the virus. If symptoms occur with acute infection, they can appear anytime from 2 weeks to 6 months after exposure. Symptoms of acute hepatitis can include, but are not limited to, fever, fatigue, loss of appetite, nausea, and jaundice. And symptoms of chronic viral hepatitis can take decades to develop. So for the next 3 slides, I'll be discussing data from the CDC's Division of Viral Hepatitis, their 2020 Viral Hepatitis Surveillance Report, which represents the ongoing systematic collection, analysis, and interpretation of viral hepatitis-related data for Hep A, Hep B, and C. So please note that the findings in the surveillance report should be interpreted with caution due to the assumption that viral hepatitis cases reported to the CDC in 2020 may be lower than years before the COVID-19 pandemic began. So although there is an effective vaccine available for hepatitis A, in the US, outbreaks are related to contaminated food or via person-to-person transmission. That being said, hepatitis A cases decreased 47% from 2019 to 2020. There's also a vaccine for hepatitis B, although about 2 in 3 people do not know they're living with hepatitis B, which is the leading cause of liver cancer. Acute hepatitis B cases abruptly decreased by 32% after 2019. Nearly 40% of people with hepatitis C do not know they're living with it, even considering that hepatitis C is curable in more than 95% of cases. Hepatitis C is the leading cause of liver transplants and liver cancer, and acute hepatitis C cases increased during 2020. Inclusively, it has doubled since 2013, and during 2020, it increased 15% from 2019. As I mentioned, hepatitis A is spread when someone ingests the virus, even if it's in microscopic amounts that are too small to see, through close personal contact with the person that has the virus, or through eating contaminated food or drink. So on the slide, I show the multi-state outbreak that was reported earlier this year. As of May 5th, 2023, a total of 9 outbreak-associated cases of hepatitis A have been reported from 3 states. Based on epidemiological data collected by the CDC, 9 out of 9 people who provided information about what they ate before becoming ill reported eating frozen organic strawberries, therefore leading to a recall. Hepatitis B is primarily spread when blood, semen, or certain other body fluids, even in microscopic amounts, from a person with the hepatitis B virus enters the body of someone that does not have the virus. The hepatitis B virus can also be transmitted by birth to a pregnant person with hepatitis B, sexually, sharing of equipment that has been contaminated with blood from someone with the virus, including needles, syringes, and even medical equipment such as glucose monitors, direct contact with the blood or open sores of a person, and poor infection control in healthcare facilities. And it's important to note that although the virus can be found in saliva, it is not spread through kissing or sharing utensils. And it does not spread through sneezing, coughing, hugging, breastfeeding, or through food or water. Similarly to hepatitis B, hepatitis C is also usually spread when someone comes into contact with blood or semen from a person that has hepatitis C. Today, not having access to sterile and individual use needles, syringes, and other equipment due to poor harm reduction policies in the US are the most common cause. As most people, that is the most common form of transmission in the US. Additionally, approximately 6% of infants born to parents with hepatitis C will get hepatitis C. And though uncommon, people can also become infected when healthcare professionals do not follow the proper steps needed to prevent the spread of bloodborne infections. Additionally, hepatitis C can spread when getting tattoos or body piercings in unlicensed facilities, informal settings, or with non-sterile instruments. And again, hepatitis C is not spread by sharing eating utensils, breastfeeding, hugging, kissing, holding hands, coughing, or sneezing. So on this slide, I am showing some key facts about vaccination for hepatitis A and B, as there's no vaccination for hepatitis C. So it is recommended that all children aged 12 to 23 months and children and adolescents 2 to 18 years of age who have not previously been vaccinated receive the hepatitis A vaccine. And for hepatitis B, all infants, children, and adolescents younger than 19 years of age, and all adults 19 through 59 years. In addition to that, for hepatitis B, anyone that requests vaccination should get vaccinated, and adults aged 60 years and older with risk factors. Ugh. All right, give me a second. All right, so one of the most impactful, all right, hold on, let me make sure I'm where I'm supposed to be. Okay, one of the most impactful barriers to treatment for hepatitis is access to healthcare, especially being able to afford healthcare and the privilege of having health insurance. Following several years of rising uninsured rates during the Trump administration, there were small gains in coverage across most racial and ethnic groups between 2019 and 2021. Despite these coverage gains, disparities in coverage persisted as of 2021. Hispanic uninsured rate remained over 2.5 times higher than the rate for white people. Even among insured people, only about 1 in 3 received timely hepatitis C treatment, and this is even lower among people with Medicaid insurance. People with Medicaid were 46% less likely to receive treatment than those with private insurance. Medicaid recipients of other races were up to 27% less likely to get timely treatment than white Medicaid recipients. And unfortunately, after the expiration of the COVID-19 public health emergency, Medicaid's continuous enrollment provision will come to an end. An estimated 4.6 million will lose coverage, which is about a fourth of all enrollees. All right, so I am pleased to highlight the phenomenal work of our partners and friends at the Center for Health Law and Policy Innovation of Harvard Law School and the National Viral Hepatitis Roundtable, specifically their State of Hep C Medicaid Access Project. To provide some background, in 2013, curative treatments known as direct-acting antiviral agents were introduced as treatment for hepatitis C, like I mentioned, offering cure rates of 95% with minimal side effects. Unfortunately, despite the important individual and public health potential of these cures, many state Medicaid programs have limited access to hepatitis C treatments due to cost concerns. So these Medicaid coverage restrictions include liver disease progression, meaning they require patients reach a certain stage of fibrosis, which is liver disease, which can be irreversible and cause cancer. Substance use or sobriety requirements, meaning barring patients with a history of substance use disorder, and prescriber restrictions, meaning only allowing certain specialists who are not readily available to prescribe a cure. Since they began publishing reports in 2017, 21 states have removed prior authorization requirement for most patients. 33 have either eliminated or reduced their fiber restrictions. 36 have loosened their sobriety restrictions, and 35 has scaled back their prescriber restrictions. So in January of 2021, the U.S. Department of Health and Human Services released the Viral Hepatitis National Strategic Plan for the United States, which is a roadmap to elimination coordinated by the Office of the Assistant Secretary for Health through the Office of Infectious Disease and HIV/AIDS Policy. And it was developed by more than 20 federal agency partners with significant input from stakeholders and the public. So the Viral Hepatitis National Strategic Plan is the first to aim for elimination of viral hepatitis as a public health threat. It sets forth a clear vision for how the United States will be a place where new viral hepatitis infections are prevented. Every person knows their status, and every person with viral hepatitis has high quality healthcare and treatment and lives free from stigma and discrimination. So it's designed to provide national, state, and local governmental stakeholders with a comprehensive data-driven approach. In 2020, the Division of Viral Hepatitis, which is part of the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the CDC, released its 2025 strategic plan, which outlines goals, strategic approaches, objectives, and outcome measures for making measurable progress in reducing new viral hepatitis infections and associated illnesses, including deaths, disparities over the next 5 years. The 5 goals outlined, 4 goals. 4 goals outlined include reducing new cases, reducing hepatitis-related morbidity, mortality, reducing hepatitis-related disparities, and establishing a comprehensive national viral hepatitis surveillance for public health action. So CDC recently published updated recommendations for hepatitis B screening and testing. In this publication, screening refers to testing people not known to be at increased risk for exposure to hepatitis B. Testing refers to conducting serologic tests of people with symptoms or who identified to be at risk for exposure. The CDC recommends screening all adults aged 18 years and older for Hep B at least once in their lifetime. To ensure increased access to testing, anyone who requests Hep B testing should receive it regardless of disclosure of risk. as many people might be reluctant to disclose stigmatizing risks. Additionally, the CDC recommends HPV screening for Hep B surface antigen for all pregnant people during each pregnancy, preferably in the first trimester, regardless of vaccination status or history of testing. In April of 2020, the CDC updated its recommendation for vaccination for Hep B to universal adult Hep B vaccination. The rationale for this recommendation is due to approximately 1/2 of acute Hep B cases reported in 2019 occurred among persons aged 30 to 49. The number of cases of acute Hep B has increased among adults aged 40 years and older, particularly among those aged 40 to 49, as Hep B vaccination coverage among adults aged 19 or older is low. So a universal recommendation for Hep B vaccination could increase the number of persons who receive vaccination, hopefully before the onset of chronic liver disease and other comorbidities that might make vaccination less effective. In the spring of 2020, the CDC updated its screening guidelines to screening for Hep C of all adults 18 and older once in their lifetime, and the screening of all pregnant people regardless of age during each pregnancy. Additionally, the guidance recommends routine periodic testing for persons that request testing, regardless of disclosure of exposures. All right, I think I'm turning it over to Zakia. This screen sharing format that I set up for myself.
Well, thank you so much, Isabel. No, it looks fine. It looks great. All right. Well, thank you. As Isabel said, my name is Zakia Grubbs. She, her pronouns, also at NASTAD on the hepatitis team. So I wanted to get us started in moving from a national perspective to a state and local response for viral hepatitis elimination. In 2021, CDC released the most recent integrated viral hepatitis surveillance and prevention funding for health departments cooperative agreement that funds 59 jurisdictions for surveillance and prevention and 17 jurisdictions for special projects related to the infectious disease consequences of drug use. With this cooperative agreement, many jurisdictions were able to fund viral hepatitis surveillance for the first time. On this slide are some of the activities that health departments are currently planning, designing, implementing, and evaluating. For many of these activities, engagement and collaboration with community-based organizations, people with lived experience, social service agencies, healthcare providers, and other community leaders is essential to reach viral hepatitis elimination, such as forming an elimination group or a stakeholders group, developing outbreak detection and response plans, assessing laboratories and health systems for their hepatitis testing practices. All of those are activities that health departments are currently engaging in. We also urge you all to reach out to your local health department and see where there's opportunities for collaboration. Okay, next slide. We also wanted to briefly highlight some of the work of a few jurisdictions with large Latinx populations and some of the work they're doing to support hepatitis services. For example, in California, the local health departments have several collaborations with Latinx serving organizations such as BNSTAR in Los Angeles to provide hepatitis C testing and support services for LGBTQ+ communities. Also, they support local health department testing programs, such as in Santa Cruz County, that works with people experiencing homelessness to provide screening and linkage to care for hepatitis. Next slide, please. Okay. In Colorado, the local health departments have collaborated with organizations to host outreach events to increase community awareness of hepatitis and provide opportunities for screening. For example, the San Luis Valley Area Health Education Center, which serves 6 medically underserved counties, provides HCV and HIV testing, linkage to confirmatory testing and care, harm reduction, syringe access, medication-assisted treatment, and other services for people who use drugs in collaboration with other local organizations, community-based organizations, FQHCs, and local health departments. Next slide, please. Great. In addition to partnering with community-based organizations for prevention activities, health departments are also convening coalitions to support viral hepatitis elimination, planning, and evaluation. On the slide are a couple of the jurisdictions that are developing or are in the process of developing these plans. For example, Texas. You can see the QR code there as well. They'll be having their first viral hepatitis elimination summit this month on May 20th. And they have been very intentional about including people with lived experience with hepatitis C and BIPOC communities in their planning. Also, we have California there, who has developed an integrated plan, and all throughout their plan, they've made sure to highlight the social determinants of health and other factors such as mass incarceration and income gaps that affect Black, Latinx, and Indigenous communities and affect access to care and have impacts on how we work towards ending the epidemics for HIV, hepatitis, and STDs. Next slide, please. So there are a lot of more state and local hepatitis elimination groups. On the slide is a picture of our NASTAD HepTac resource bank microsite, where you can find your jurisdiction, their coalition's website, and their current plan. Also, if you all need any assistance with getting in contact with your local planning group, please reach out to us. Next slide. I also wanted to highlight Hep B United, which is a national coalition comprised of advocates, community leaders, and stakeholders that focuses on health equity, respect, and empowerment of those affected by hepatitis B. Hep B United supports local coalitions to raise awareness, provide education, screening, and vaccination services to the community, and also support initiatives to increase access to hepatitis B testing, vaccination, and treatment services, especially among populations that are disproportionately affected. We encourage you to reach out to Hep B United if you would like more information about joining your local coalition, or if there isn't a coalition in your location, definitely feel free to reach out to them if you're interested in starting a coalition in your area. All right, and I wanted to finally highlight some resources that are available for clients and providers on this page. And on the next one are some fact sheets from the Latino Commission on AIDS, our gracious host today, and CDC and other sites that are available in English and Spanish. Next slide. There's a few more there. And also, I wanted to highlight some of the resources that are available for healthcare providers, clinical and outreach staff, and other folks that provide viral hepatitis services. These links include more in-depth hepatitis data, information on viral hepatitis serology, hepatitis A and B vaccine resources, and information on treatment and linkage to care. And next slide. I think we have reached the end of us talking, but I guess we can get into some questions if you all have them.
Yeah, thank you very much, Zakia and Rita, Isabel, for the presentation. I'm waiting for questions from the audience, but there's one here from Iber Gonzalez. She said, if we have a rapid hepatitis C test, the next step would be to do a genotype confirmation test. Is it necessary to know genotype to start treatment?
That's actually a great question, Yvette. So in the United States, we actually do not have a confirmatory rapid hep C test. And so the next step would be to, in a laboratory, get your confirmatory testing, and genotyping is not necessary to start treatment.
Well, people get more motivated to ask questions. We know that hepatitis B and hepatitis C affects everybody. And we Latinos are not the group most affected. And we are with third place, I think. But we, I think I read somewhere that we Latinos, when we get hepatitis, we progress faster to complications than chronic hepatitis or cancer. Why is that?
That's actually a great question, Luis. It's really in regarding the disparity. It's actually Latinos being Latinx populations being diagnosed later. So there's more progression of their disease. Inclusively, there's data to suggest that they are treated later versus white counterparts. And so that is also a massive contribution. And if we think about hepatitis B as well, we see in the United States amongst foreign-born populations, and that is especially because in their countries of origin, their health systems did not provide Hep B vaccination upon birth, and so that is why they progressed to Hep B. Additionally, we see that social determinants of health, such as mass incarceration, also hold a role, considering that Latinx populations are incarcerated at higher rates versus white counterparts. That puts them at an increased risk to not only not be screened, but especially not be treated.
And this is why we basically do this campaign. People, Latino communities get to know all the resources that are available for treatment, prevention, and vaccinations and cure hepatitis, hepatitis. But many people don't know. We mentioned that Latinos progress quickly because they don't know, they don't have it. And unfortunately also hepatitis C, I think people living with hepatitis C, 50% don't know they have it because they haven't tested at all. So knowing the risk and knowing when you are putting yourself at risk of hepatitis, you should take a test at least to know where you are in that. There is a question from Anonymous. What information do you have about disparities among Latinos in the US? Latinos are a very diverse community from many countries of origin. Do you have disaggregated data by country of origin?
That's a great question. So in terms of hepatitis C, and if we're thinking about the standardized data that like I showed in the surveillance report, no, that data is not disaggregated by country of origin. We do know our partners at Hep B United work towards disaggregating that data more further. They inclusively have a mixed methodology. So in addition to surveillance, they have storytelling, they have interviews with folks, and that contributes to the whole picture, and that gives us a better sense of data such as country of origin. But at this time, we do not. And I do agree, absolutely. It's important that we, especially when I transitioned from global health to domestic health, I noticed very quickly I was no longer like Mexican. I was then like put into a box like Latinx. And so I think something that we think about, or I think about, that it's true, Latinx, we're not a monolith. We are diverse.
And it depends where in the country you are. Because if I'm in California, everything Latinx is Mexican. If you're in New York, everything is Puerto Rican.
Exactly.
Florida.
Yes.
So everything changes depending where in the country you are. And as well, I mean, the biggest part of Latinos in the United States are Mexicans, not foreign, but Puerto Ricans and Dominicans. So it's mostly the mixture of all the cultures is not as mixed as people think. And yes, we are all diverse, different colors, different sizes, different everything. But that's the beauty of it.
If I could add really quickly, I guess I had also mentioned that in terms of surveillance data, a lot of jurisdictions are just now receiving funding for surveillance, and they're currently building that up. But I think that is a good opportunity for advocacy and working with your health departments and your healthcare providers and asking for them to disaggregate that data and have more options for when reporting race and ethnicity. So there's definitely opportunities for that. Unfortunately, we don't have it right now, but in the future, we definitely should.
Exactly.
In the years I've been doing this, I noticed that the disease reports are being more, have more information at the beginning, because many cities or states they reported at the beginning, and now they are reporting, and there's more information. The reports are looking better every year. Still more questions here. Another anonymous, he says, why if the data doesn't demonstrate the impact of Latinx communities? Is it possible that individuals identify as other?
So it's interesting because the amount of resources that are allocated to the public health infrastructure for viral hepatitis does not compare to the burden. Inclusively, we are just now starting in the third year of a cooperative agreement by the CDC to build out both prevention and surveillance in jurisdictions. And in the majority of these jurisdictions, they hadn't built out, or they didn't even have staff to build out surveillance programs. So especially looking at the response to COVID and trying to leverage the building out of that infrastructure, hepatitis is just slightly behind. And it is possible, though, that, as Zakia mentioned, not only that individuals identify as other, but also one of the sources of data for public health is like electronic health records. And so if providers do not fill out the demographic information, then public health doesn't have access necessarily, or electronic lab reporting that also, there is also initial reporting demographic data through that. And I would say it is then a combination also of that, along with individuals identifying as other.
Also, I noticed in the formularies that you feel about your race or ethnicity in many places. For me, for example, I'm Latino, right? I'm Peruvian, but I don't find where to mark because I am asking, are you white? Are you black? Are you Asian? Are you this? And neither one of those is me. I'm a mixture of something. So I don't mark anything. And then at the end, I have to explain. And some people don't take the time to explain anything either. So, yeah, I think that's a problem. And it should be corrected in many of those places. So it's another question. There's an increasing population of indigenous populations from Latin America who may not speak Spanish, have different cultures than other Latinos. They need to be considered in the strategies.
Absolutely, absolutely. Inclusively, we have been contacted to see if we can find interpretation, especially for indigenous languages from different states. And it's unfortunate because the resources that they can allocate to the translation is not, it's minimal. It's quite, there's lots of room for improvement in that area. But yes, I agree. They do need to be considered in the strategies.
That's an area for advocacy, right, Zakia? So what is the best way to increase hepatitis awareness directed to Latino communities? I feel there are some resources in Spanish, but there is still a gap.
Absolutely. I would say if starting maybe on the more macro level, especially considering what we mentioned about coverage in healthcare and having insurance, that is one area where we need to improve. So we need to really expand, dare I say, to universal healthcare coverage, as it is, having healthcare is such a privilege in this country. Especially with the expiration of the COVID-19 funding. So many are going to go without health insurance. I think it's also faults in the healthcare system itself. So there isn't really an approach to empowering or client-centered or person-centered care in the US, because there's a vaccine for Hep B, there's cure for Hep C, there are ways to prevent it, and yet people are still being impacted. And so that means those are systemic failures. Those are really failures of higher level, macro level failures. And so another piece that's important is the representation among providers being Latinx. Even just the exorbitant cost to attend medical school and higher level education it's ridiculous. It's obscene. And there needs to be more efforts for us to make sure there's representation among our providers and our clinicians. I'm going to pause there.
But nurses and nurses, everybody who works in the hospital health system, we need more representation, that's for sure. And about these parties, I think we already knew that very well. HIV is very notorious as well. But then COVID came and definitely demonstrated, showed to everybody that these parties exist, and the Black community and the Latino community are the most affected by almost everything in this country. So there's definitely our work to do in terms of advocacy and for our rights, and especially healthcare. There's another question. There are major disparities in hepatitis vaccination coverage among Latino adults particularly Mexican and Central American foreign-born persons. Because it's likely an important issue. What can be done to address that barrier? Same applies to testing.
What can be done to address that barrier? I mentioned universal healthcare coverage. I think an important piece that is missing is patient-client navigation. I will say even my prior experience as a clinician, I had trouble navigating the healthcare system. And so I think really having those representatives from communities to provide that link, I think is also a major gap. And it's especially considering the resources that are allocated, especially for folks that are doing DIS work and linkage to care. And in addition to the navigation, we need to really to really empower that workforce, but also making sure that they are paid adequately and really invest in that area.
Any other questions?
Yeah.
Presenters? Well, a little bit clinical. You said that there is treatment for hepatitis B, right?
Yes.
There's no cure for hepatitis B yet. So what
No
is
cure for no cure for B, cure for C.
Yeah. So what does the treatment for B do?
So there's similarly to HIV, there are antiviral treatment, and that is also for life.
Okay. Then you viral goes and take the one, you keep it like that for as long as you can.
Correct. Until there's a cure, hopefully.
I heard some people who have hepatitis B been treated, and they are untreatable for many years, and all of a sudden they also decide to vaccinate this person for hepatitis B. Why is that?
That's a good question. I know it's not in the guidelines, but I also know that if people request vaccination, they're given it. Did that answer your question?
Yeah, because I think if I have hepatitis B, for example, and I already developed my antigens and everything, and I get treated, so I'm not supposed to get it again. Expected I can, right? But I'm getting vaccinated for hepatitis B again, it means I can get it again. Is it possible?
No, I don't think there's science to support that.
Okay. I was wondering why.
I know, exactly.
Hepatitis C, you can get it again after you cure.
Correct. Yes. And hepatitis A.
Yeah, hepatitis
A.
How many times have you been infected? Correct. And that's why the reason why you can get infected again with hepatitis C is the reason why you have all these laws about treatment for hepatitis C, correct? Because a person who uses drugs or is alcoholic should not be considered the same as other one because he's going to get infected again. That's what people think.
Well, we contribute it to. Well, first, we don't have proper harm reduction policies in place. We do not. There isn't an incentive in the U.S. to provide that infrastructure and really support people who use drugs. So they do not have access to equipment that is sterile. It's just for them. And so that is a big policy failure on our end. Additionally, we do not interpret the Medicaid restrictions as in benefit or person-centered. We do more interpret them as stigmatizing and discriminatory. And so this is also based on the fact that it saves so much more costs down the road when we treat people and we prevent versus waiting for them to progress to liver transplant or cancer, and then unfortunately untimely death.
And also the cost of treatment is much cheaper.
Substantially, yes.
So eventually everything will be better if we do the right thing, but we still don't do it.
Exactly. Theoretically.
Yes.
You would think.
Yes. Okay. Any other question from the audience? Any other question for our presenters? Oh, giving you about 15 minutes. Well, thank you very much, Isabella. Thank you very much, Zakia, for your presentation, for the questions, and for being out with NHHAD again. Hopefully, we'll have you again next year or maybe before for any other thing. And we are Latino Commission are eager to collaborate with you on anything you need for us. And for you, there's a question. Yeah, need Canales. Not a question, but we have love to have Spanish translation available for learning speaker. Okay, perfect. Thank you. We'll take it into the consideration for the next one. But I always feel like here I speak in Spanish, and if I speak in Spanish, if you have any question, you can ask me in Spanish. I will be replying in Spanish as well. No problem.
That's true. I did offer too. I said, should we do it twice?
And please join us next 15th in the day of National Hispanic Hepatitis Awareness Day. We're having a webinar with HEPU, and they're going to present the importance actually with surveillance system that are done in the United States and how these results influence a lot of the laws that we have for hepatitis. Oh, your presentation. Thank you, Kelly. Thank you, everybody, and thank you again, Isabel, and thank you, Stia. See you.
Thank you.
Thank you for having us.